On the lowest rung of the ladder is the split skin graft. The constituents of this graft are the epidermis and the superficial part of the dermis. Well, based on the thickness of the graft, it has been classified into thin, medium, and thick. The thickness of a split skin graft varies from 0.15 millimeter to 0.6 millimeter. A thin graft is the one which is considered to be 0.15 to 0.3 millimeters thick. A medium thickness graft would be 0.3 to 0.45 millimeters thick, and a thick graft is 0.45 millimeter to 0.6 millimeter in thickness. The point to be emphasized is then that whenever you are dealing with a bed which is not the optimum of situations, there may be some little bit of infection or the granulation tissue is not very good, then a thin graft has a better chance of surviving than a thick graft. So whenever there is a doubt, it is better to use a thin graft. The incorporation of a split skin graft is drawn over the next 5 to 7 days after the graft has been placed on the bed. Well, the stages have been divided into 3. The first stage of incorporation is known as the imbibition stage, which lasts for the first 48 hours, and this is due to the fact that the split skin graft is a free graft, and when it is placed on the host bed, it is totally dependent on deriving its nutrition through a process of diffusion or imbibition. So there are no vascular connections at this point in time, and it is a process of diffusion which keeps the graft alive. The next step is inosculation, which concerns establishment of small little vascular connections over which starts at around 2 days time or 48 hours, and it lasts for the next 5 to 7 days. The next stage is the stage of revascularization, which is an advanced stage taking a cue from the stage of inosculation, and as stated earlier, it would take about a week's time for this process to be complete. So the bottom line here, the lesson for the orthopedic surgeons is that if you have performed a skin grafting procedure on the limb, it would be better to instruct the patient not to move his foot or the hand for the first 48 hours, because that is critical to avoid any friction or traction in between the surfaces of the skin graft and the host bed. What are the prerequisites for embarking upon a split skin grafting procedure? The host bed on which the split skin graft is going to be dependent for the first 48 hours on the process of diffusion needs to be highly vascular. And it should also be remembered that a split skin graft would survive on bone only if its periosteum is intact, because periosteum is a vascular structure. The cortex of the bone is comparatively avascular. Cartilage with perichondrium and tendon with paratenon are again prerequisites for a split skin graft to take on these surfaces. And it is needless to say that there is a possibility of graft failure if you are putting a graft on an infected bed. So ideally, no infection should be present when one embarks upon split skin grafting. Well, in the next few slides, I would show you these procedures on a few of the patients which I have dealt with during my career as an orthopedic surgeon. And this patient was a patient who came to us, a young man, fell from a motorcycle, had an accident, and he had a severe soft tissue loss right from the knee down to the ankle, along with a fracture of both bones leg. So it is according to Gustello and Anderson classification, this would be somewhere near a grade 3 injury, and amongst the grade 3, since there is extensive soft tissue loss, it would be 3B injury because there was no neurovascular deficit. The fracture was stabilized by an external fixation system, and you can see the pins are bent here because the whole assembly is in compression. And there is beautiful granulation tissue which has been created with daily dressings with petrolatum gauze. And the bed is now, it's fit for a split skin grafting because 3 repeated pus culture sensitivity reports came out to be negative. The patient was examined, the X-ray was examined, and it was found to be adequate reduction, and it was this reduction was absolutely stable. The patient was able to move the ankle and the knee joint as is recommended in these procedures. Well, a serial split skin grafting was performed, and at the end of about a month, this was the result. There is total coverage of the soft tissues by a split skin graft, which is not only providing a biological cover now, there are no chances of an infection occurring to the deeper tissues now, and with this coverage, this patient required a bone grafting procedure because the fracture went into delayed union, and following bone grafting, it ultimately united in 6 months' time.